Polycystic ovary syndrome. It's a heterogeneous clinical syndrome characterized by the hyperandrogenism, menstrual irregularity, and polycystic ovarian morphology, in which there is other causes of androgen excess should be excluded. The diagnosis is further supported by the presence of characteristic ovarian morphology. A distinction is made between polycystic ovarian morphology on ultrasound and PCOS, the syndrome, where PCO polycystic ovary is also associated with other features of polycystic ovarian syndrome, such as hyperandrogenism or menstrual disturbance. Many causes of hyperandrogenism mimic features of PCOS, including PCO morphology. The international PCOS guidelines recommend that CH should be excluded in all patients with a measurement of 17 OHP during the follicular phase. Investigations for the rare condition, such as Cushing syndrome, should only be conducted if there is a high index of suspicion. PCOS is the commonest endocrinopathy in female of the reproductive age. 95% of the female presenting in outpatient with hirsutism have PCOS. The estimated prevalence of PCOS ranges between 5 to 13%. PCOS ovaries, polycystic ovaries on ultrasound alone are present in 20 to 25% of the female of the reproductive age. First relatives of the female with PCOS have increased prevalence of metabolic syndrome and obesity other than the general population. The fundamental pathophysiological defects unknown, but both genetic and environmental factors are thought to play an important role. In the genetic, familial aggregation of PCOS is present in 50% of the female. A family history of type 2 diabetes is also commoner in female with PCOS. PCOS is probably a polygenic disorder. Implicated genes include those of the insulin pathway, testosterone biosynthesis enzymes, and obesity-related genes, including the FTO gene. The main source of hyperandrogenism is the ovaries, although there may be adrenal androgen hypersecretion, particularly in lean women with PCOS. The biochemical basis of ovarian dysfunction is unclear. Studies suggest an abnormality of cytochrome P55C17 activity, but it's unlikely to be the primary event, but rather an index of increased steroidogenesis by ovarian theca cells. There's an increase in the frequency and amplitude of the GnRH pulses, resulting in an increase in the LH concentration, which is present in 50% of the female, although this may be blunted in obese females. So the Joint European Society of Human Reproduction and Embryology and American Society of Reproductive Medicine consensus are the diagnostic criteria of the PCOS. That is the Rotterdam criteria. According to that, at least two out of the three should be present. First is oligomenorrhea or amenorrhea, hyperandrogenism, which could be clinical or biochemical, polycystic ovaries on ultrasound, and exclusion of the other disorders like CH, hyperproteinemia, Cushing, if indicated. Other causes of hyperandrogenism include CAH, acromegaly, Cushing syndrome, testosterone secreting tumors, most commonly adenoblastoma. So hyperinsulinemia. 70% of the females with PCOS are insulin resistant, depending on the definition. The defect in the insulin sensitivity appears to be selective, mainly affecting the metabolic effects of insulin, that is the effects on the muscle and the liver, but sparing the ovaries, where insulin acts as a cogonadotropin to amplify LH-mediated testosterone synthesis. Hyperinsulinemia is exacerbated by obesity, but can also be present in lean female with PCOS. Type 2 diabetes, diabetes mellitus is 4 times higher than age-matched controls and tends on the average to occur 4 years younger than in the unaffected female population. There's also evidence in the increased number of female with PCOS of the insufficient beta cell response to glucose challenge, which is known to be a precursor to type 2 diabetes. Insulin also inhibits sex hormone binding globulin synthesis by the liver with a consequent rise in the free androgen levels. So the features are symptoms often begin around puberty, mostly after the weight gain or after stopping the OCPs, but it can present at any time. Oligomenorrhea and amenorrhea is present in around 70%. It is due to anovulation. Hirsutism is present in 66%. 25% of the female also suffer from acne or male pattern alopecia. Virilization is not a feature of PCOS. There is often a family history of hirsutism or irregular periods. Slower onset of hirsutism makes a distinction from adrenal or ovarian tumors, which are rapidly progressive and more likely to be associated with virilization and higher testosterone concentrations. Less than 1% of the hirsuite female have a non-classic CH, and this should be excluded, particularly in female with significantly raised serum testosterone levels. Obesity is present in 50% of the patients. Symptoms worsen with obesity as it is accompanied by increased testosterone concentration as a result of hyperinsulinemia. Acanthosis nigricans may be found in 1 to 3% of the insulin-resistant females with PCOS. Infertility is present in 30%. PCOS accounts for 70% of the cases of anovulatory infertility, and the risk of spontaneous miscarriage is also thought to be higher than in the general population, mainly because of obesity. Depression, mood disorders, and obstructive sleep apnea are the other features of PCOS. It is very important to rule out an androgen secreting tumor if there is evidence of virilization, testosterone level is greater than 5 nanomole per liter or greater than 3 nanomole in postmenopausal women. If there is a rapidly progressive hirsutism, CT of the adrenals or the ultrasound of the ovaries will detect tumors greater than 1 centimeter. Selective venous sampling occasionally is necessary to locate the virilizing tumors undetected by the imaging. Ovarian suppression test using GnRH analog can establish ovarian origin of androgens. Adrenal tumors usually co-secrete cortisol as a part of Cushing syndrome. So the main things which should be kept in mind to screen for the androgen secreting tumor are virilization, high level of testosterone, rapidly progressive hirsutism, and incidental findings of the tumors. So the risks associated with PCOS are type 2 diabetes, which is around 4 times more common in female and affects 10 to 30% of the female with PCOS. Gestational diabetes is also more prevalent in these women, and the prevalence of diabetes increase in all female with PCOS, but is highest in the obese group. The most important risk factor is the family history of type 2 diabetes. Dyslipidemia. Several studies have shown increased risk of hypercholesteremia, hypertriglyceridemia, and low dense LDL, low HDL in PCOS patient. Endometrial hyperplasia and carcinoma in anovulatory female. There is endometrial stimulation by the unopposed estrogens, which then results in endometrial hyperplasia. Studies have demonstrated that this affects is a 2 to 4-fold excess risk of the endometrial carcinoma in female with PCOS. Thus, it is recommended to induce at least 3 to 4 withdrawal bleeds per year to reduce this risk in amenorrheic female. Meta-analysis also suggests a 2-fold increased risk of arterial disease in female with PCOS relative to female with without PCOS. Pregnancy in women with PCOS. There are adverse pregnancy outcomes, including increased miscarriage, increased risk of gestational diabetes, increased risk of hypertension, and increased lower segment C-section out ratios. So the investigation of PCOS are, first of all, it is very important to confirm the diagnosis. For this, we need to do few tests, including the testosterone concentration. It is often normal in female with PCOS, and the serum androgen concentration do not reflect the degree of hirsutism because of the variable androgen receptor sensitivity. LH concentration The higher the LH level, the more likely the risk of anovulation and infertility, and cannot be used to diagnose PCOS. It is raised in early half of female. So testosterone concentration, it is often normal in PCOS patient, and LH concentration, the higher the LH concentration, the more likely the risk of anovulation and infertility, and it cannot be used to diagnose PCOS as it is raised in only half of the female patients with PCOS. Sex hormone binding globulin, it is low in 50% of the PCOS patient owing to the hyperinsulinemic state with a consequent increase in circulating free androgens. It's a useful indirect marker of insulin resistance, although it can be low in obesity more generally. Free androgen index, it is calculated by 100 multiply total testosterone divided by sex hormone binding globulin. Image made by the pre-antral follicles are raised in PCOS. It can be useful non-invasive alternative to ultrasound, but image does not yet form part of the diagnostic criteria, whereas PCO morphology does. Pelvic ultrasound of the ovaries and endometrium. So ultrasound criteria for PCO defined as greater than 20 follicles between 2 and 9 millimeter in diameter, or ovarian volume greater than 10 centimeter cube. If using transabdominal ultrasound, a volume of 10 ml should be used as follicle number is unreliable. Ultrasound is sensitive but not specific, occurs in CH and Cushing, usually transvaginal but transabdominal possible in experienced hands. False negative results common in non-specialist scans. Measurement of the endometrial thickness is of major importance in the diagnosis of endometrial hyperplasia in the presence of anovulation. Endometrial hyperplasia is diagnosed if the endometrial thickness is greater than 10 millimeter. Transvaginal ultrasound will also identify 94% of the ovarian virilizing tumors. Associated endocrinopathies include prolactinoma, serum prolactin in the presence of infertility or oligoamenorrhea. Mild hyperprolactinemia up to 200 milliunit per liter is present in up to 30% of the female with PCOS. 17 OHP level, it is used to exclude the late onset CH. It is indicated in those with testosterone concentration in excess of the 5 nanomole per liter are the evidence of virilization. So one is high testosterone level and the other is presence of virilization. Sometimes we need to perform the sonactin test if basal 17 OHP does not exclude CH to look for the exaggerated rise in 17 OHP in response to ACTH in the presence of non-classic CH. If the patient is ovulating, then all 17 OHP measurements should be performed during the follicular phases of cycle to avoid false positive due to pregnancy. DHEA sulfate and androstenedione concentration both can be moderately raised in PCOS, although DHEA is traditionally considered an adrenal androgen. Adrenal androgen excess may be a part of particular relevance in lean female with PCOS. So basically, in lean PCOS, adrenal androgen may be measured. Adrenal, and it's not need to be measured routinely in female with PCOS, but indicated if the serum testosterone is greater than 5 nanomole per liter or in the presence of radial progressive hirsutism or virilization. Screening for the complications, including the blood glucose level and lipids, OGT, if the BMI is greater than 25, or age 40 years, history of gestational diabetes, a family history of type 2 diabetes. Now the management of PCOS. The management should be personalized to the patient's symptoms, including the hirsutism, ovulation, and amenorrhea. take into consideration the need for the contraception. First of all, weight loss, and studies have uniformly shown that weight reduction in obese female with PCOS improve insulin sensitivity and significantly reduces hyperandrogenemia. Obese female are less likely to respond to anti-androgens and fertility treatment. With a loss of 5%, female with PCOS show improvement in hirsutism, restoration of the normal regularity, menstrual regularity, and fertility. Metformin in obese and lean insulin-resistant female with PCOS. Metformin improves insulin sensitivity with a corresponding reduction in serum androgens by up to 11%, and an LH concentration, and an increase in the sex hormone binding globulin levels. Metformin may regulate menstruation by improving the ovulatory function, but improved live birth rate is not established. Metformin does not seem to improve response rates to ovulation induction using clomiphene citrate or gonadotropins. Evidence suggests that metformin is no better than lifestyle at improving metabolic risk and progressive to type 2 diabetes. Metformin is usually stopped at the onset of at the diagnosis of pregnancy, as benefits in pregnancy is not proved outside of the established GTM. There have been few long-term studies looking at the effects of metformin on hirsutism, and it appears that the effects are modest, and most female with significant hirsutism will require an anti-androgen. Female should be warned of the side effects possibly related to the GI. Hirsutism. Pharmacologic treatment of hirsutism is directed at slowing the growth of the new hair. It can be combined with mechanical methods of hair removal such as electrolysis and laser therapy. Therapy is most effective when started early, and there's a slow improvement over the first 6 to 12 months of treatment. Patients should be warned that facial hair is slow to respond, treatment is prolonged, and the symptoms may recur after discontinuation of drugs. Adequate contraception is mandatory during pharmacological treatment of hirsutism because of the possible teratogenicity. The pharmacological treatment of hirsutism include combined OCPs. So basically there are different mechanisms, and for that different drugs are used. So for the ovarian androgen suppression, combined OCP is used. For the adrenal androgen suppression, corticosteroids are used in rare cases. And for the androgen receptor antagonism, spironolactone, cyproton, steroid, and flutamide are used. And for reductase inhibitors, including the finasteride, can be used. Insulin sensitizer, including the metformin, is also used. So the combined oral contraceptives. The estrogen component increases the sex hormone binding globulin levels and thus reduces the free androgen concentration. The progesterone component inhibits the LH secretion and thus ovarian androgen production. The effect of the OCPs alone on the hair growth is modest, so it may be combined with anti-androgens. Cyprondiol, which contains CPA, or yasmin, which contains drospirenone, may have additional benefit because the progesterones are anti-androgenic. So combined OCPs, the estrogen would increase the sex hormone binding globulin levels as we discussed. So androgen receptor blockers, these include spironolactone, cyproterone acetate, flutamide, and 5-alpha reductase inhibitors. And so androgen receptor blockers, first of all, spironolactone, it is anti-androgen of choice, particularly in the overweight female. The dose is 100 to 200 mg. Side effects include polymenorrhea, if not combined with combined OCPs. And few patients may complain of the GI side effects and high dose of spironolactone. Potassium levels should be monitored. Cyproterone acetate, the dose is 25 to 100 mg, and it is given on days 1 to 10 of the pill cycle in combination with combined OCPs. Side effects include amenorrhea if given alone for the prolonged periods or in higher doses. Progesterone side effects include hepatic toxicity, but it's rare. But monitoring of the liver function 6 monthly is recommended. A washout period of 3 to 4 months is recommended prior to attempting contraception. Frutamide is a potent anti-androgen. The dose is 125 to 250 mg per day or 1 mg per kg daily may be effective and associated with a lower frequency of hepatic adverse effects. LFTs should be monitored pre-treatment and monthly for at least 4 months, then as indicated. Side effects include dry skin, nausea in 10%, is 0.1 increase, 0.4% risk of the hepatic toxicity, and it should therefore be used with extreme caution. Bisulfite reductase inhibitors, they convert the conversion of testosterone to the more potent androgen DHT. Finasteride dose is 1 to 2.5 mg once a day. It's a weak anti-androgen. The side effects include no significant adverse effects, and it can be used as monotherapy or combined with other anti-androgens. Adequate contraception measures are necessary because it is teratogenic. In addition, pregnancy should not be attempted until at least 3 months after the drug cessation. In fluoromethane, 11.5%, it irreversibly blocks the enzyme ornithine decarboxylase, which is involved in the hair growth of the hair follicles. It is administered as the topical cream on the face to reduce new hair growth, and studies have shown its efficacy in the management of mild facial hirsutism following at least 8 weeks of treatment. Treatment should be discontinued if there is no benefit at 4 months. It is not a capillary cream and so must be combined with mechanical methods of hair removal. The side effects include skin irritation with burning or pruritus. As far as the amenorrhea is concerned, a minimum of withdrawal every 3 months minimize the risk of endometrial hyperplasia. The treatment includes combined OCPs, cyclical progestogen, including the desogestrel, is a progestin-only contraceptive pill with minimal androgenic properties. Metroxyprogesterone in the dose of 5 to 10 mg PID for 12 days of each calendar months can be used. Norethiostrone should be avoided as it is more androgenic. Metformin, 1 gram 2 times a day, which is also improves lipoprotein pattern. As far as the infertility is concerned, ovulation induction regimens are indicated. Obesity adversely affects fertility outcome with poorer pregnancy rates and higher rates of miscarriage. So weight reduction should be strongly encouraged. So the agents include letrozole. It inhibits the aromatase, which reduces the estrogen production, leading to reduced negative feedback and thus increased gonadotropins. So basically, it acts by reducing the negative feedback at the hypothalamus level. It is associated with improved live births and pregnancy rates compared to clomiphene citrate when used to cause ovulation. It has a short half-life and does not deplete the estradiol receptors throughout the body like clomiphene citrate. And it was not used for many years due to concerns about the congenital malformations, now thought to be unfounded. Currently remains off-label. This clomiphene citrate currently is still used as the first-line agent. Clomiphene citrate is a selective estrogen receptor modulator which inhibits estrogen negative feedback, increasing the FSH secretion and thus stimulates the ovarian follicular growth. The dose is 25 to 150 mg a day from day 2 of the menstrual cycle for 5 days. The response rate at 80% for ovulation rate to 67% pregnancy rate. The complications include 8% have 8% have twins, 0.1% higher order multiple pregnancy, risk of ovarian neoplasia following prolonged clomiphene treatment remains unclear, so limit treatment to a maximum of 6 cycles. Metformin. Its use remains controversial, but probably does not improve the pregnancy rate in insulin resistance, particularly overweight with PCOS. Emerging reports of higher BMI, increased risk of obesity in children exposed to metformin in utero, but generally thought to be safe in pregnancy. No reported teratogenic effects have been observed. Start at a dose of 5 mg OD with the largest meal to minimize the GI side effects, and it should be increased gradually to 1 gram BID. If ovulation restored following 6 months of treatment, then continue for up to 1 year. If pregnancy does not occur, then consider other treatments. Gonadotropin preparations, including human menopausal gonadotropin or FSH. It is used in those unresponsive to clomiphene citrate. Low dose step-up regimens show better response rate and fewer complications by increasing the chance of achieving monofollicular growth, that is 75 international units per day for 2 weeks, then increase by 37 every 7 days if required. It is associated with 94% ovulation rate and 50% pregnancy rate. Complications include hyperstimulation, multiple pregnancies, and close ultrasound monitoring is essential. Surgery. Laparoscopic ovarian diathermy or laser drilling may restore ovulation in up to 90% of the female, with cumulative pregnancy rate of 80% within 8 months of treatment, particularly affecting slim female with PCOS and high LH concentrations. It is invasive and could adversely affect ovarian reserve. Complications include surgical adhesions, which may be mild. IVF. In female who fail to respond to ovulation induction, a third will have live birth with each IVF cycle. For acne, the treatment of acne should be started as early as possible to prevent scarring. All treatments take up to 12 weeks before significant improvement is seen. All treatments, apart from the benzoyl peroxide, are contraindicated in pregnancy. In mild to moderate acne, topical benzoyl peroxide 5% bactericidal properties may be used in conjunction with oral antibiotic therapy to reduce the risk of developing resistance to antibiotics. And in case of moderate to severe acne, topical retinoids, including tretinoin, isotretinoin, it's useful alone in mild acne in conjunction with antibiotics and moderately severe acne. Oral antibiotics, including oxytetracycline, doxycycline, minocycline, can be used in these patients.